Thank you, Alex, for the kind introduction, and thanks for the opportunity to speak to you today. Before I get started with the official part, though, I'd like to extend a personal note, which is a big thank you to all of you for the work you do every single day to diagnose us cancer patients, treat us, and give us longer quality lifetime. Thank you very much for that. Today, I speak to you as a member of the Patient Advisory Council of the German Cancer Research Center and as a deputy spokesperson for the Patient Research Council at the National Center for Tumor Diseases in Germany. Thank you for giving me the opportunity to share a patient advocacy perspective on what defines true excellence in cancer care. Now, what defines excellence? Comprehensive cancer centers, or CCCs as we heard and know, are designed to deliver high-quality care, research, and innovation. But patients experience quality in a different way than clinicians or researchers do. This includes understanding where to go, being part of the treatment decisions, managing side effects early, having equal access to innovative trials, and being involved in shaping research. When I was first diagnosed 5 years ago, my adventure in the German cancer care system started. I'm doing fine at the moment, but I'm sure that my adventure isn't over yet and will continue. The cancer care system can feel like a maze. Patients often struggle to find the right people, appointments, or information, especially if they live in rural areas or face other barriers. Patient navigation programs can help. They provide guidance through diagnostics, treatment, and follow-up, and they coordinate care across departments. Some facts: a review of over 300 studies showed that navigation improves outcomes for patients and makes healthcare more efficient. And efficiency or efficient systems save cost as well. Helping patients navigate the system to us patients is a core part of quality care. The next topic is shared decision-making. Shared decision-making means patients and doctors make treatment choices together. This includes medical facts, but also what matters to patients personally, like goals, fears, family, work, or life priorities. In many cancer cases, there is no single right choice. Patients weigh survival against quality of life for a very variety of reasons. The Share to Care project in Germany, for example, showed that patients who took part in STM felt better prepared, more satisfied, and more confident, and the therapy adherence was higher as well, leading to a much higher probability of a successful therapy. In my own treatment, I was faced, that was 3 years ago, having to decide between continuous therapy, where I take modern pills for the rest of my life, or a time-limited therapy where I only took the pills and medication for a year. I had little guidance and no one took responsibility. So I decided, me as a patient, I have to take responsibility myself. I informed myself, got into a clinical trial, and after a year of medication, I've been in complete remission now for 2 years and hopefully for another couple of years. Quality of life and side effects. That's another very important story. For patients, quality of life is an extremely central topic. So it's not only overall survival, where you maybe don't have a real quality, but it's the real quality of life. Fatigue, pain, appetite loss, these are just side notes, but they shape everyday life. Doctors define different stages of side effects or adverse events. For us patients, not only the severe ones matter, but also, or even more, the so-called minor symptoms deserve full attention, especially when they occur over a longer period of time. And I'm happy to share again a very personal example. During my treatment, I suddenly got neutropenia grade 4, which rang all alarm bells with my medical staff. I had to come into the hospital right away. I didn't understand why. They said it's life-threatening. I didn't feel it. I didn't feel anything. So I got shots, which got it back on track. 6 months into my therapy, though, I started suffering of diarrhea, which for the clinicians was not really a big deal. So it was along the lines, go and take care of yourself. To me, it was a really hard thing because it impacted my life, and I had to do a lot of stuff in order to live a normal life again. I even developed a map of the city of Munich with all public toilets within 5 minutes reach. Next is equal access to cancer innovation. For this piece, I would like to acknowledge that what I'm going to say now relates to Germany, so a first world country. Equal and fair access to innovative cancer diagnosis and treatment in low and middle income countries, as we heard today, is a completely different story and deserves conferences and talks on their own. So let me talk about access to innovative research in Germany. In Germany, we do have excellent CCCs, but many of them are in large cities, as has already been said previously. In rural regions, patients often have fewer opportunities to join clinical trials or be part of specialized tumor boards. Data from Bavaria, for example, and you see sort of graph in the bubble, show that although 30% of the population lives in rural areas, only 17%, so a little bit more than half of it, of these patients are in molecular tumor boards coming from these areas. So we need more outreach and more coordinated outreach. This includes shared tumor boards in partnerships between CCCs and local oncologists with their private practices, and also more telemedicine. We also need, and that goes specific for Germany, a change in compensation of private oncologists. Cooperation has to be rewarded, not competition. Because today, if the patient is gone from the practice, the money is gone, and that's a big problem. Let me add a couple of words about the National Center for Tumor Diseases, or NCT. It's a long-term collaboration between the German Cancer Research Center and comprehensive cancer centers across Germany. What makes the NCT special is the clinical translational research and the fact that patients are structurally involved in this research. At the NCT, patients are members of the Patient Research Council. We, together with researchers and clinician scientists, design clinical trials, give feedback on study protocols, make sure that documentation is developed in lay language so that patients understand it, and we even help define research questions. To support this, we are running our own, what we call Patient Expert Academy, where we train patients on very, very deep medical and clinical and trial things. And we also, on the flip side, train up clinicians on how to best embed patients in their clinical trials. What do patients expect from CCCs now, or in general, comprehensive cancer centers? First, we want to understand the systems they're in. We need a map. So if you go on vacation to a new city or a new country, the first thing you do, you buy a map in order to find your way around. And that's exactly what we need as patients, so that we understand what's been brought upon us, how to navigate the system, and even how to ask the right question. Secondly, we want to be asked what matters to us along the lines of shared decision-making, so making the right decision where we are included. I'm not saying we need to be part of the tumor boards, that probably goes a little bit too far, but we want to be presented options, and we want these options to be discussed with us in order to make, together with the medical staff, the right choices. Third, we want our symptoms to be taken seriously, even those that don't seem medically relevant at the first look. Fourth, we want to access the best care, no matter where we live, whether in the city or in rural areas. And fifth, we want to contribute shaping the future of research. We as patients, we can offer disease-specific first-hand information. That's something researchers don't have, and we're happy to share. Thank you very much for your attention, and I'm happy to answer any questions.